Hey guys, how's it going? Today we're going to be doing our first video in critical care. So we're going to start with airway access and intubation. Um, the way you can think about it is as a doctor, imagine you have a patient in front of you who might crash. First thing I ask yourself is, do I need to secure the airway? Very important thing, very important for all doctors. So make sure you guys pay attention to this video and let's make it easy and understandable. So what questions do I need to have if I have a patient in front of me who might crash, or someone who I think might crash? Um, I need to ask myself a few questions. Is the patient talking? So talking is very important. If the patient cannot talk, that means he may crash soon. So he may crash very soon. Second question is his GCS less than 8? If his GCS is less than 8, that patient is going to crash soon. I have to be very, very careful. The other thing is, does this patient have any facial trauma? So is his facial bone broken? Is there injuries in his nose and other parts of the airway? So this type of patients can crash very soon. Other type of patient that may crash is someone with burn injuries, or someone with let's say lip swelling or angioedema, right? In all these cases, if you're suspecting that this patient is going to crash soon, you got to be prepared. You got to be ready to intubate him. But you just can't go ahead and intubate him. You have to ask yourself, do I have time or not? If they're crashing or seizing, no time. Just go ahead and intubate. If they're stable, then you can plan it better, right? So let's say they're crashing. You think they may crash soon. The golden standard in medicine or in emergency critical care is the RSI, which is the rapid sequence intubation. Let's say patient is awake, right? But he can't protect airway. His GCS is 6. In that case, you just can't just shove the tube inside his mouth. He will gag, right? Or vomit or fight. So what you need to do in that case is you sedate the patient, then you paralyze him, and then eventually you intubate him, right? So that is what is called rapid sequence intubation. Sedate the patient, paralyze him, and then intubate him. So for sedation, usually they use propofol, and for paralyzing the patient, they use succinylcholine, and then they intubate the patient. So the way you can think about rapid sequence intubation is sedate the brain, paralyze the body, and then intubate. Right? So what about some patients who may have a huge neck, right? A, a big neck, or someone with lots of facial injuries. What are you gonna deal with them? Are you just gonna do the rapid sequence intubation, or you have to do some further investigation before you intubate the patient? In these type of scenarios, what you can do is you can use this video laryngoscopy or fiber optic intubation. It's very simple. They just put the fiber optic intubation, or they put a laryngoscopy tube inside the patient's mouth, and then they see the vocal cords on the camera to make sure that he is ready to be intubated. So it's like a pre-planning before intubation is done. So anyone with a big neck, anyone with facial injuries, don't intubate the patient right away. If there is time, if the patient is not crashing too fast, go ahead with video laryngoscopy and fiber optic intubation. The third thing, this nasotracheal intubation. This is a sneaky route. Let's say I really can't use the mouth. Why wouldn't you be able to use the mouth? Patient may just had an oral surgery. So someone who just had an oral surgery, you just can't intubate him, right? Someone, let's say with another example would be someone with someone who can't open his mouth, let's say trismus. So someone who can't open his mouth, you just can't forcefully open his mouth to intubate him. You just leave his mouth alone, sorry. So in these type of scenarios where mouth access is not possible, you go ahead through the nose. Okay, but there is a situation that you can't use the nose. One of which is skull fracture. If you're suspecting a skull fracture, don't use the nose for intubation. Or if someone is having a massive nosebleed, then in that scenario, don't use the nasotracheal intubation. So how are you going to think as a smart doctor? If the patient is crashing, go ahead and use the RSI. That's the gold standard. Sedate the patient, paralyze the patient, and then intubate him. If there's a difficult airway, such as a big neck or facial injury, let's say an obese lady with rheumatoid arthritis can't move his neck, then you ask for video laryngoscopy or fiber optic intubation. And then someone who had recently done a oral surgery, or a guy with a tetanus, rigid jaw, then you can go ahead for nasotracheal intubation, which is the third one. I hope you learned something new today. Have a good day.